The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I'm Gary Swartz, Associate Executive Director, American Academy of Home Care Medicine, and welcome to this afternoon's webinar, Nurse Practitioners and Physician Assistant, Practice Challenges and Opportunities. First, we want to welcome you to this afternoon's webinar and let you know they're great days ahead for those of you providing house calls, those of you on the call, and those of you across your practices as well. So keep doing the good work you're doing, persevere, and know we are here to help. We also want to let you know we want to see you and your colleagues in less than 2 months at the annual meeting to meet with you, and also so that you can enjoy the collegial and peer-to-peer discussions at the meeting, both in formal settings and informal settings. And for those of you wondering about the sustainable growth rate formula that you may be seeing about in your emails during the end of this week, a bill to patch has passed one house of Congress. However, organized medicine opposes this patch as it contains harmful long-term provisions and also does not address the SDR long-term. The Senate's understood to be working to improve it. We will keep you informed, and you also want to make plans now to get through, let's say, the weeks of April and end of April if Congress does not act soon and claims are held or processed at rates with the SGR in effect. So we're going to send out this information again through the e-news the beginning of next week, unless some changes are made in Congress at the end of this week. But I want to let you be aware of this recent information so that you can plan accordingly. We're going to leave some time in the middle of the presentation so you can email us how you're overcoming obstacles in your states regarding practice, so you can share that with others on the call. The webinar goals and outline. We want to develop a baseline of practice consideration, what type of practice and setting is realistic, and we'll discuss the set of issues that follow that. We want to talk about opportunities and overcoming obstacles in practice, describe where we go from here, and then provide time for questions and feedback. So what type of and setting of professional practice is realistic? The issues that many of you have had to, on the call, have already had to address, and some of you are still working through on a state issue or considering as you consider practice in other areas or expansion, state corporate practice of medicine issues, state scope of practice laws, state culture and professional relationships, patient population, demographics and payer source, business financial factors, practice management, capacity, and expertise. In terms of the corporate practice of medicine in general, this restricts practice to licensed professionals as in the best interest of patients. There's often exceptions to that, those rules and statutes across the country in statute or in practice. And so you need to find out, can NPs and PAs own a practice, or must it be a physician? And then, and then if so, what can your relationship be with those individuals, and how can you successfully structure and practice? Again, that varies across the country on a state-by-state basis. And then, even if you can legally organize and structure the practice, can you find those who will collaborate with you on the collaborating agreements that are required for your practice? Will the boards of medicine, the boards of nursing, et cetera, corporations understand what you're trying to do? We have had to send in information that nurse practitioners, for example, were not seeking to establish home health agencies because there was confusion even on a state level, or there was opposition to the practice of house calls by non-MDs. So again, you need to understand the state's culture and professional relationships, and what sort of education process may be necessary. And again, we're here to help you with that. Patient demographics and payer source need to know where the patients in need of house calls are, how you can see them efficiently, what sort of payment resources are available, and understanding we will talk about this in a few moments about health plan relationships as well. Business financial factors. What will you require in terms of working capital? What do you have established so that you can get a practice up and running or expand the practice or open up into different areas? And you need to plan for months of operations, and that would include your business relationships and partners, anybody working for you, the infrastructure cost, and of course your own compensation. And again, we'll touch on that a little bit more. And then the practice management capacity and expertise. What is that you have yourself and we can assist you with at the Academy? What can you build within the practice? And then also what you can buy from a vendor or partner relationship. What revenue cycle, billing and coding services are there in the community and that are familiar with house calls practice. Moving down to the state scope of practice for nurse practitioners. Just about every state requires a national certification. What you want to find out on a state level is, are you eligible, this is important for multiple reasons, are you eligible for Medicaid payments on a state level? And while you're generally seeing Medicare patients, which is recognized, the dual eligibles and Medicaid managed care is becoming a growing area of interest and opportunity. So you want to know if you're both eligible for Medicaid payment, and then moreover, are you eligible to be a Medicaid primary care provider? This is important not only so that you can receive payment directly from the state Medicaid departments, but also that you can then contract and become part of the health plans as your states move into Medicaid managed care. This is also important as the states regulate health plans on a state level, and this sends a message to those health plans, and also the requirements of the ACA may provide some additional inroads in that area. Moving further in terms of state scope of practice issues, what does your state permit for nurse practitioners? What's the extent of practice authority to diagnose, treat, and refer? What are the levels of prescription authority? Only non-controlled substances, or does it include controlled substances as well? How will you address issues, and what provisions are there for hospital admissions, signing death certificates, involuntary admission? This is often under different state statute names in different areas of the country. For example, Florida may be called the Baker Act, but basically provisions for involuntary admission. And then what opportunities are there to be medical directors of continuing care retirement facilities or other types of facilities on a state level? Our understanding is that these areas are becoming more permissive around the country, and then these are also areas where you're going to have workarounds established for patient care and practice success. We're going to talk about the collaboration agreements when they're needed to be in place in states that where you can't practice completely independently. What are the state requirements, the meaning of requirements, and then payment for collaboration agreement services. Across the country, in terms of the minimum requirements, 24 states provide for independent practice, and within those 24 states, 16 include prescription authority, full prescription authority, and 8 do not. 11 states require a moderate level, have a moderate level of requirements. They require collaboration agreement for consultation referral and a review of provided care. And then the most extensive requirements are those in 15 states that require written guidelines or protocols that may restrict your scope of practice to less than your training. This is a map that will be included in the slides that are posted to the site. This comes from the American Association of Nurse Practitioners. And generally this reflects that the West and the Northeast have the provide for the most independent practice. The Midwest and the Rust Belt are somewhat in the middle, with the South being the most restrictive region of the country in terms of scope of practice. This slide is taken from model legislation of the National Council of State Boards of Nursing, and I just wanted to provide you language that might be helpful if you're working from an advocacy perspective within your states on state scope of practice, that you have this language. And again, this information is also included in a reference slide at the end of the presentation. And this provides the language about scope of practice. Again, this is model legislation from the National Council of State Boards of Nursing, and what model legislation is used is to present and to be made available for advocates in different states, and to try to get states to be in conformity with this language across the country. And then, as we saw in the prior slides, that's not the case now, and this is a model that they'd have provided to adopt. This model is also referenced in National Governors Association materials as well, to have the services of more nurse practitioners are available for primary care across the country. Payment for collaboration agreement services. We are sometimes asked this question, and generally what we find is that this is dependent upon state culture and professional demographics, the relationship of physicians and nurse practitioners and PAs, and the relative ratio of those, and the cultural background, and then also what the marketplace will bear. What we receive in terms of feedback, in terms of payment and compensation that's required for those collaboration agreements, is that it's generally a matter of reverse engineering or working backwards from physician annual compensation, being paid on a monthly basis pro rata for the volume of patients, or on an hourly rate that would then be built up to equal primary care physicians' annual compensation, or a set fee per NP for that collaborative agreement services. What we would encourage, and we can post some model agreements for you as well, is that you obtain not only the minimum required services in terms of that supervision and chart review, et cetera, but also review of patient care, the chart review, quality assurance, using both an evidence base from medicine and also from nurse practitioner literature, and to contribute to team-based care and practice opportunities as they will continue to grow in these with these collaborative relationships. State scope of practice for PAs. How does the state regulate PAs? And again, are you eligible for Medicaid payment? And are you eligible to be a Medicaid primary care physician? And again, these issues vary across the country, and we also have a map that will reflect this as well. State scope of practice. What does the state permit in terms of PAs? The practice authority, again, the licensure as the regulatory term for PA, and you want to work to modify from certification or registration, if that's the legislation, the designation in your state, as these are often confusing to patients and to others, and may be considered to have a more generic meaning than licensure. Prescription authority, again, what is the scope provided in terms of prescription authority? So that includes just non-controlled substances, or does that extend to controlled substances as well? And then this is also from model provisions from the PA Association, which recommends that the scope of practice be determined by the supervising physician, the PA, and that any facility in which you're providing your services. And again, have it be done on that interpersonal and professional level rather than at a macro state regulatory level that may not take into full consideration your training experience and the relationship, again, with the physician and the practice in which you're working. So you want to provide for adaptable supervision requirements, that the co-signature requirements are determined on a practice level, and that there's no physician to PA ratio limitation. These limitations are often just done routinely on a 4-to-1 basis, that is one physician per 4 physician assistants in the various states. And again, you want to have that done at the group level, practice level, or at the facility level. This is this is a map reflecting the prior elements that were across the top here, and reflect by coloration which states have adopted those recommended elements, going from the red and orange coloration colors being 1 or 2 elements through to the darker green elements of more opportunity and flexibility at the practice level for PA practice. Again, this is not a perfect reverse of the NP map, but it does reflect that in areas of strong physician relationships and influence, there seems to be more practice flexibility for PA practice, for your professional services in those states. Instead of a collaboration agreement, there's the delegation agreements between physicians and physician assistants. This slide presents the AMA guidelines for those relationships, and again, this will be posted to the Academy site. From these guidelines, the physicians responsible for managing care, services delivered by the physicians and physician assistants must be within the scope of each as defined by state law. Physicians responsible for coordinating and managing care with the input of the physician assistant. Physicians responsible for supervision across all settings. The role of the physician assistant defined through the mutually agreed upon guidelines developed by the physician and the physician assistant based on the physician's delegatory style. Physician available for consultation in person or by telecommunication. Physician assistant involvement in assessment and implementation of treatment depending on the complexity and acuity of the patient, and also the background and training of the physician assistant. Patients, and this applies also for nurse practitioners, should be made aware excuse me about the typo there, at all times by whom they are being cared. Physician and physician assistant should review delegated services on a regular basis, as well as the mutually agreed upon guidelines for practice. Physicians responsible for clarifying and familiarizing the physician assistant with his or her supervising methods and style of delegating patient care. So again, these are the recommended guidelines by the AMA to have included in those agreements in the practice or in the facilities. Moving on to Medicare coverage basics. Again, these are cited in the reference slide at the end, and will be posted, and links provided to the MedLearn materials for that Medicare has provided for limited licensed practitioners under Medicare Part B for coverage and payment. Won't walk through these on a line-by-line basis, but just want you to to be aware that they are available for you, and would think that those of you on this call already have these structures and processes in place. But if not, they're here for you as a reference, and again, we're also available for questions here at the Academy. So this is the Medicare coverage basics for nurse practitioners. continuing on a service basis. I want to mention one thing at the end that we get questioned about, both for on a physician assistant and PA level, and that is about incident to services. While the incident to concept is available to physicians and to nurse practitioners and physician assistants as well in office settings, it doesn't work because there's in the house call setting, because there's a supervision requirement requiring for one site sort of under the roof access to the physician that the services are rendered incident to. And in the house call environment, there wouldn't be really a reason for the two professionals to be in the same location at the same time. So it's a concept that really isn't clinically or economically feasible in the house call environment. There are some isolated exceptions to incident to, that is in rural areas where the availability of home health and nursing is not available. But again, that's a rather fine exception to the general concept. Claims submission information is here. And then, as you know, that services are paid at 85% of the amount that a physician is paid under the physician fee schedule. And reviewing some materials for this presentation, it isn't clear where that number was derived, about the history of that number. And that figure, of course, is inclusive. That is the Medicare allowed amount for your services, and then within that would be the 20% that the beneficiary is responsible for paying. Medicare coverage basics for PAs follows, and again, the same organizational and structural legal requirements, and these will be available for you. And again, that services are paid at 85% of the fee schedule. Okay, let's move on to opportunities and overcoming obstacles to practice. These opportunities are brought about by an increase in the number of multi-morbid home limited. And we know that your services and your practices only reach a minority of the total patient population that is really in need of house calls, and that's considered to be generally 1 out of 4 in need. So we know that the opportunity is there. We also know the opportunity is there through our growing practices and those speaking to us about what they're encountering in the field of just really unmet demand for their services as they market the practice and present information about the availability of the services and just about the concept of house calls, that the tremendous uptake and appreciation that the service could be available. Through the ACA and coverage expansion, there's understood to be an increase in the number of required office visits of between 15 million and 25 million by 2015. And of course, generally this is considered in terms of office visits, but we also do know of the unmet demand for house calls as well. What this all really goes to is that there's an increase, that there'd be a requirement for an increase in number of PCPs needed over this time frame between 4,000 and 7,000 across the country to meet that number of millions of increased visits. And the good news is that the increase that nurse practitioners are expected to increase in number from 128,000 in 2008 to nearly double that, or 244,000 by 2025. And also there's a similar nearly doubling roughly doubling of PAs expected from 74,800 in 2008 to generally around 150,000 in 2025. So the great news for patients in need and those of you in practice in terms of the opportunity and the growing your practice is that there'll be a growth hopefully in the number of colleagues with which you can work to meet these the needs of the beneficiary population. So what are some of the obstacles to be overcome? And we want to discuss and leave open for you some of the professional workarounds that are required. Going into an area, there may be a lack of physician support who will sign off on prescriptions, again, depending on the state that you're in, and if established practice or considering practice, who's going to sign off on home health orders, order of complex diagnostics, well, you can order the mobile x-ray, et cetera. What might be the requirements for more intensive diagnostic services? What are the relationships that would need to be established for hospital admissions and care relationships and continuity of care? What practices could you relate to if there are issues on a state level, particularly on the private health plan area of relationships with health plans and becoming a participating provider, and then local culture issues and others. One thing I want to mention here is that there is also a need to develop a group culture as you're growing your own practice, that everybody is working for the entity, the practice, and that we're really not working and just taking care of our own panel of patients, that you have meetings to discuss care and you become familiar with each other's patients. This is beneficial both not only for patient care, but also for cross-coverage relationships. It's also helpful in group presentation and negotiations that there is a group culture, an identity established in negotiations with other parties. And this also helps just within the group practice environment when it comes to things such as scheduling, seeing each other's patients, the days off that we need sometimes on a planned and unplanned basis, holiday and vacation coverage. So do want to note that developing a group culture and having this in mind when you are interviewing, recruiting and interviewing and orienting new physician assistants, new nurse practitioners to the practice, as it would be for new physicians as well, is very important. And we hear from practices that sometimes those that they are recruiting and bring on board simply do not work out from that perspective of house calls practice and a group culture understanding and demeanor. With this, though, I want to pause here for a moment and give you some time to email us with how you have developed professional relationships and workarounds to overcome these obstacles in your community. I'm going to go back to that slide, and again, I'll provide for a few minutes here so that you could email, and please share this with your colleagues, and as those emails come in, I'll read those off, and we will also post these with the slides. And again, these are some of the, oh, I'm sorry, to use the chat box that's on the webinar. I misspoke. The questions box. Again, these are some of the areas that may require workarounds and development of relationships, and we have some ideas to share, but we'd also like to hear from those of you on the webinar this afternoon. And again, could be some other issues you've had to address that were obstacles to your getting up and running in practice, and that you have found a way to overcome those obstacles and to grow the practice. Okay. While you're sending those in, we'll go ahead and talk about some of the opportunities and some of what we hear from those of you in practice on some of these topics, and talk about some of the opportunities. But again, please share with your ideas and send those in, and we'll share those with your colleagues. Okay, in terms of practice opportunities, again, there's local, regional, and national community private practice opportunities for license-led independent practice, and also team-based practice. Again, we saw in the maps and earlier in terms of scope of practice, which states provide for more greater professional opportunities initially without the relationships established. There are health system-based practice opportunities for you, both in teaching and non-teaching settings. There are health plan-based practice opportunities, increasingly accountable care organization, and other shared savings models, post-acute bundling opportunities-based practices. We have calls coming into the practice, into the academy, from health agencies and others, moving into house calls as an understanding of the growth in demonstrations and shared savings models, and that includes, as you may know, there was one announced that we included in the e-news newsletter earlier this week. There's also community-based, again, this community-based non-acute or post-acute opportunities, and also the community-based organizations such as practice and health centers and facility practice